On behalf of the SOE, I would like to welcome you to the SOE webinar on oncology and pathology. It is my pleasure to organize this symposium, this webinar, together with Professor Heinrich Heimann from Liverpool. You can see Heinrich here. My name is Nikos Bechrakis. I'm working in Essen in Germany. I think we have some very good presentations on various topics in ophthalmic oncology. This session will be recorded just for your information, and there is a Q&A section at the bottom of your screen. You can share your thoughts and put your questions in the Q&A section, so we can look it over and then discuss your questions after the pre-recorded talks. The talks are pre-recorded. We will have 5 talks, and we will start with Rumana Hussain from Liverpool. Then we will go, she will talk on small melanocytic lesions, and then we will go on with Heinrich Heimann. We'll talk on biopsies. Miltos Fiorensis from Essen will talk on surgical resection on Uvil melanomas. Jens Kilgart from Copenhagen, Denmark, will talk on how to improve survival of Uvil melanoma, I think a very important issue. And the last talk will be by Eva Bierwald from Essen on salvage treatments on retinoblastoma. So I hope you enjoy the webinar, and we will start with Rumana Hussain's talk that is called Choroidal Melanocytic Lesions, When to Watch and When to Treat.
Hello everybody, good afternoon. Thank you for inviting me, for giving me this talk. My name's Rumana. I work at the Liverpool Ocular Oncology Centre, and I wanted to talk about lesions like this, really. So these are the kind of lesions that we get in the ocular oncology unit, and you can see that there's a wide range of different phenotypic types. You've got suspicious lesions that have subretinal fluid, although this looks a little bit chronic because of the drusen. This is quite raised. This has orange pigment and subretinal fluid, and this just has orange pigment. So with all these variations in phenotypes, how can you tell what is benign, what's malignant, and how can you tell what you should treat and what you shouldn't? The problem is that all of these images are of choroidal melanomas that have been biopsy proven, and actually all of them are not only that, they are melasma 3 tumours, which means that they have a high risk of metastatic disease and they're highly lethal tumours. So it is important to try and differentiate these, whether they're large or small, what type of tumour they are. And the Shields group, over 20 years ago now, described a number of risk factors to try and give us some kind of clinical clues to see whether we can differentiate malignant disease from benign disease. So orange pigment, subretinal fluid, large tumours, and low reflectivity on the ultrasound. Lesions near the disc have now been scrapped on the more recent updated guidelines from 2018, and visual symptoms, which was a bit non-specific, has been replaced by something more specific where the vision has dropped due to direct results of the tumour. And so because of that, the Oncology Centre, for every single patient, goes through each of these modalities of imaging, really to look for every single one of those risk factors. Probably the most difficult risk factor to spot clinically is orange pigment, mainly because the choroid is kind of a similar colour to the orange pigment, so the contrast isn't there. The easiest way to pick that up really is with autofluorescence, and you can see the hyper-autofluorescent areas that really highlight those areas of lipofuscin and also highlight the areas of exudative activity around it. So autofluorescence is really very useful. And although it can pick up this orange pigment on the pigmented lesions, on the more amelanotic types, you can see the pigmented, partially pigmented lesion. You can see these orange areas on the pigmented part, but in the non-pigmented part, these appear brown, but they appear as similarly hyper-autofluorescent on the autofluorescence picture. So the autofluorescence will really give you a clue as to whether there's lipofuscin or not. So if you take something like this reasonably simple case of a small lesion, it's near the disc, but we know now that that's not a relevant risk factor. And if you look at the autofluorescence, there's no activity on here. There's no orange pigment. There's no signs of exudative changes. The OCT doesn't show you much other than some nerve fiber layers through the disc, but if you focus a bit further back with an EDI OCT, you can see it quite nicely here. This choroidal lesion, it's very small, there's no fluid, there's no risk factors, And so this is a simple choroidal nevus. And so this is easy enough, no risk factors, choroidal nevus, benign lesion. Although the risk of this turning into a malignant melanoma is extremely low, it's not zero. And so we do recommend that these patients get long-term monitoring, but that doesn't have to be in the hospital setting. That can really be in the community as well. And a lot of optometrists are quite happy to do that. The main thing is to make sure that they have a baseline photograph so that in the future, if there is a suggestion of change, you have a baseline image to compare it to. On the other end of the spectrum are these larger pigmented lesions. So you can see this large pigmented tumor here that actually is quite diffuse in its nature, orange pigment, so much subretinal fluid that it's now caused an exudative retinal detachment with a solid tumor underneath. And on the ultrasound, sometimes, not only is it low reflectivity, you can see these blood vessels pulsing within it to give you an idea that it's more a malignant tumor rather than a benign tumor. And this one is obviously going to be treated. It's a malignant melanoma. The question is, why are you treating this patient? They have no visual potential. The only treatment for something like this is enucleation. And so the reasons really to treat this is if this tumor is allowed to continue to progress, you will get a further exudative detachment, sometimes rubiotic glaucoma, and then end up with a painful blind eye, which will end up needing enucleation anyway. And also the other reason is if this tumor progresses, you may get progression through the sclera and extraocular extension, which in itself is a risk factor, independent risk factor for increased metastatic disease. So those are the reasons really to treat these big tumors as you would expect. But realistically, you want to catch them more when they're at this level. So this is another melanoma with orange pigment, subretinal fluid, over 2 millimeters on the ultrasound and low reflectivity that you can see on the image there. But because it's smaller, you can now treat that with plaque brachytherapy. You can preserve the visual structures like the disc and the fovea, and that means you can treat this safely, preserve vision, preserve the eye. And so you want to treat it more at this stage before it progresses to that more advanced stage that we saw earlier. The more difficult ones are something like this. So this is a patient with a lesion very close to the fovea, but completely asymptomatic. So you'd assume that something active here would give you some visual symptoms, but this patient had none. The lesion has some orange pigment over the top and maybe a bit of subretinal fluid, but the ultrasound isn't very typical, medium reflectivity also. The patient at the bottom, similarly, atypical lesion, but the lesion has no risk factors such as orange pigment or subretinal fluid, but has low reflectivity on the ultrasound. And so with these lesions that are a little bit in the middle, you haven't got anything definitive to say it's definitely a malignant melanoma or it's definitely a benign lesion, you have one or two risk factors. We call them indeterminate choroidal lesions, and it's reasonable then to monitor them to see if they progress. And this is the whole point of photo documentation, making sure they have a baseline photo, because without a baseline photo, it might be difficult to see that along this blood vessel here, you can definitely see this tumor is progressing. This is getting thicker. There is more obvious orange pigment, and this is definitely a melanoma. Even in the one below, if you don't have a photo, it would be very, very difficult to spot that this area is getting bigger and thicker. And again, this is a melanoma as well, because it is progressing. Even more difficult are some of these ones. This is an amelanotic lesion with partial pigmentation in the middle and around the outside of it. But if you look at the OCT, you can see it's coming from the choroid. It's got a little bit of subretinal fluid. The autofluorescence does show that this area of pigment is actually lipofuscin because it's highlighting on the autofluorescence. And you can see this exudative activity down here. And actually the dynamic B scan does show you low reflectivity with a nice slice through it, just like a melanoma. So actually this is a choroidal melanoma. Problem is, do you treat these small melanomas? You can see this area, this one here is a small melanoma. It's less than 2 millimeters thick. It's very close to the fovea. And this is a picture from earlier, another small melanoma very close to the fovea. In asymptomatic patients like these, do you treat these? Because actually, any treatment that you give around this area is going to cause significant visual deterioration for the patient who otherwise may have not noticed this if they were picked up on a routine eye check. And this all stems back to slightly traditional thinking about melanomas, where the thought process is that by the time they present to us as clinicians in the oncology clinic, their threshold event for getting metastatic disease has already happened. And so anything we do in terms of treatment or in terms of therapy is not going to change their metastatic potential because it's already occurred. They already have micrometastases in the blood, and there's nothing we can do about that. That is all an assumption based on slightly dated and probably slightly indirect evidence. And so if you look at some of the older evidence, this is very old evidence of patients who had enucleation, so these are quite large tumours. Their peak of metastatic disease is about 2 years after their treatment at baseline here, which suggests that the metastatic event happened prior to that treatment. But like I said, this is old data with larger tumours who all needed enucleation way before digital imaging and OCTs, where we really weren't looking at and picking up smaller tumours at that stage. And this may be the case for larger tumours, but perhaps not for smaller tumours. The other piece of evidence is that a proportion of patients do have tumour cells circulating in their bloodstream at presentation, but not all of them do. And again, this increases your risk of metastatic disease and is a predictive factor for metastatic disease, but maybe it doesn't occur in those with smaller, lower risk tumours, and perhaps this is more apparent in those with higher risk, larger tumours. And if you look at some mathematical modelling evidence, again quite old evidence, if you take a lesion, a metastatic lesion, and you extrapolate that tumour doubling time right back to when that metastatic event happened, it on modelling occurs way before presentation to the initial ophthalmologist. But again, this is a modelling system that assumes that tumour doubling time is constant throughout its lifespan. We know that that's not really the case in tumour cells, where they have different tumour doubling rates according to the blood supply and according to the environment around it. So I would challenge that thought process that we had in the past, that event of metastatic threshold has happened in all the patients that present to us in clinic. The problem is that metastatic disease is not easily treatable. All the agents that we have at the moment aren't particularly successful, and even the new agents tend to be in a very small subgroup of patients, either with localized disease or with a certain subgroup HLA subtyping. So realistically, we would like to try and catch these lesions before they metastasize and maybe treat them before they occur. We know the risk factors for metastatic disease include age, sex, ciliary body involvement, extraocular extension, the cell type, the genetic subtype of the tumour. None of those we can change, really. We can't have no influence over that. The only thing we can influence is the size threshold at which we decide that we want to treat these lesions. And we know that size matters quite significantly. It's not just the Shields group. Many, many papers have shown that the smaller tumours metastasize a lot less than the larger tumours. The question is that because the smaller tumours tend to be more benign, the more disomy 3 tumours, and the larger tumours are more likely to be monosomy 3, or is it actually because if you treat them earlier, they metastasize less? As we looked at this a few years ago at basically all our small tumours, so these are tumours less than 2.5 millimetres in thickness, of which we treated about 1,200 cases over the last 15 years or so. And of those, about 200 of them not only had a histopathological diagnosis, cellular diagnosis of melanoma, but also a quarter of them were monosomy 3, which completely goes against the thought process that all these small tumours are benign disomy 3 low risk tumours. Almost a quarter of them are high risk, potentially fatal tumours. And if you look at their absolute risk of metastatic death from metastatic melanoma, these are the small monosomy 3 tumours, these are the large monosomy 3 tumours. You can say there's a significant difference in the mortality rate when you treat these small tumours than if you treat the large tumours. And even if you correct for lead time bias statistically, that relative risk is a lot lower in the small monosomy 3 tumour group. So how can we try and find these tumours early and treat them early and maybe prevent metastatic disease before that threshold event? In the community, a lot of imaging techniques are much more common, so digital imaging and OCT, so we're detecting them a lot sooner. We also want to be thinking about them earlier when they're smaller, even in the general clinics where we're looking for all those risk factors, subretinal fluid, orange pigment, the ultrasound, for example. And we want to be treating them sooner rather than later, rather than monitoring these obvious melanomas. Even though they're small, we'd like to be treating them sooner rather than later. So in summary, nevi are easy, watch them, but they do need a baseline photo, and they need watching in the long term, whether it's in the hospital setting or in the community. The ones with 1 or 2 risk factors and you're not quite sure and you cannot definitely say this is a malignant melanoma or this is a benign lesion, you can watch them for progression, but again, they need serial photography to make sure that any changes are noticed earlier. The larger tumours are mainly treated, so the big melanomas, to try and retain as much vision as possible, to try and retain the eye as much as possible, and to reduce the risk of extraocular extension. But I think our focus in the future will be these smaller melanomas, which theoretically, if we treat them earlier, may be our only way of influencing patient prognosis in the future. That's it for me. Thank you very much for your attention.
Thank you very much, Romana. Excellent talk. I don't see any Q&A questions in the Q&A section, but I would like to ask you, there has been a recent publication by Bertel D'Amato that introduced a different kind of screening system, the mole system. Do you use it at all? Or could you say something about this, or do you use the TFS or MDIM classification?
The moles by Bertel is actually really very good. I think it's a really good screening tool. I think it's mainly for optometrists and general ophthalmologists. And I think for anyone who's thinking about referring to an oncology center, that would be a really good checklist to go through, because not only is it quite definitive and it's got in between, it's not yes or no, it's got kind of half, I'm not sure about orange pigment, for example. It also excludes ultrasound, which is really handy for people who don't do ultrasounds all the time. And so I think that is very good for people who are referring. As far as when they get to the oncology center, I think we use basically the TFSOM because those are the things that we look for.
Heinrich, is there any comment from your side?
Well, you talked about the risk factors. Is there any combination of risk factors that, is there a weighting basically between one or the other so that you're really concerned or not concerned?
I think tumor progression is definitely a very strong risk factor. If you have definite evidence that this tumor or this lesion is growing, that would be my strongest worry if I saw a patient like that. But in terms of the indeterminates, for example, I think the strongest risk factors would be orange pigment and subretinal fluid out of all of them. And those are the ones mainly to look out for. And they're reasonably easy to pick up, I think, with OCTs nowadays and autofluorescence. They're not that difficult with the tech we've got now.
I think from my point of view, a very important thing that you've talked about and discussed is that there is a differentiation between monosomy 3 small and large tumors. And the traditional thinking some decades ago was that this was not the case. And so I find this very important to see, even in these cases where we know that there is a monosomy, to treat them as early as possible in order to avoid, if it is possible, metastasis. So there must be other drivers for metastasis next to monosomy.
I think so, and I think that's the problem that we've had in the past, and it's something we need to challenge, is the thinking that all these small tumors, if they're melanomas, are all disomies, and we know they're not. And I think that's the argument that's been there for a long time. All these small tumors, they're all kind of a bit benign, aren't they? So let's just watch them, and I think that's not true.
I see there is no question at the Q&A. So thank you very much, Romana, for this fantastic talk. And we will move on with Professor Heimann's talk on current indications and limitations of intraocular biopsy.
Thank you for giving me the opportunity to talk on indications and limitations of intraocular biopsies. In Liverpool, we are one of 4 adult ocular oncology centers in the UK. We usually see about 1,000 new patients a year, with a little dip during the COVID crisis. About 300 melanomas per year, and we perform between 60 and 90 biopsies per year. Regarding the technique, about 90% of our cases are now done with transretinal biopsy and about 10-11% with transscleral biopsies. Regarding the technique, the transretinal biopsy is a 3-port vitrectomy setup, but no vitrectomy. We go through the retina into the tumor, remove tissue, check that we have enough cells that we can see, and then remove the ports without any tamponade or retinopexy. For the transcleral technique, we perform a scleral flap, then a cut down to the choroid. We use the Essen forceps to get material out of the tumor, and then we use tissue glue to seal this tunnel for cells that they don't escape. We check for cells, and after we sealed it with tissue glue, we put a plaque straight on to minimize the risk for seeding. We do histopathology and genetic analysis on all cases, and these are our indications that I want to show you in more detail with pictures. The most important indication is a prognostication. So we know this is a melanoma based on the clinical diagnosis, but we want to know what is the prognosis for metastatic disease. Now, if you don't do a biopsy, you can put in the risk factors into a risk predictor. The adjusted life expectancy of that group is there, and you know it's a malignancy, but you don't know is it a high risk or low risk malignancy, so your prognostication for survival would be somewhere there. If you do a biopsy and have a disomy 3 tumor, you will get this result. You put all the individual risk factors, including cells, in there, and you can see that this patient does not have a higher risk compared to the general population. With monosomy, obviously this is different, and you see how these prognostic curves vary depending on the biopsy result. Now, at the moment, it may be for information only, but we're at the sort of really new step of having treatments now beginning to work for metastatic disease. So the next step likely will be to identify the high-risk patients for neoadjuvant treatment. So watch this space. I'm sure it's going to change very soon. Prognostic or diagnostic in small tumors, Rumana already talked at that. We are quite aggressive with the treatment because no specialist on the planet can tell you is this a melanoma or not. And if it's a melanoma, is it monosomy or disomy? And if it is monosomy, can you make a difference with treatment? We think we can make a difference, as Rumana pointed out in her paper, that smaller tumors with high-risk characteristics have a better survival than large tumors. So treating them early possibly is your only chance to prevent metastatic death in these patients. And this biopsy, for example, in that patient is a small melanoma with monosomy 3. The next group of indications, in about 11%, is diagnostic. So all the experts in the world every once in a while see cases where they really have no idea what this is. And this is one of those cases. This diffuse swelling around the optic nerve head, no other symptoms, no other diseases. We really don't know what this is without a biopsy. Turned out to be acute myeloid leukemia, so possibly a life-saving biopsy. We all have these odd cases, a pigmented tumor, but it seems to be not only in the choroid, but going into the retina. Lots of exudates, very not typical for any type of melanoma. So is this an adenoma? Is a melanocytoma breaking through? A biopsy will tell you this is a choroidal melanoma. The next group, in about 6%, are metastases of unknown primary. Here you can clearly see these are metastases, multiple in the other eye as well. But in about 30% of our cases with metastasis, we have not a known primary. And two problems about this. Number one, metastatic disease in the choroid can grow very, very quickly and affect your vision within weeks, really. And number two, it can be really cumbersome and a lengthy process to do all the scans and screens to find out where the primary is. With a biopsy, you have the result in 1 or 2 days. So this turned out to be a breast carcinoma. So you shortcut the diagnostic circle. In lymphomas, you definitely need a biopsy for tissue diagnosis because any kind of chemotherapy will depend on the tissue diagnosis. So you can't do without it. And this is in about 6% of our cases. Now, what are the complications? No result is the biggest complication. So the patients are very disappointed. We try to get better and better, and we have no histology now in less than 5%, no genetic result in less than 10%. From the surgical point of view, a vitreous hemorrhage is the biggest complication and about 10–15%. Again, we try to get better and better, but this is not a problem we can eliminate. And even worse, a subretinal hemorrhage, this case of a 70-year-old man with a new tumor. The son had a choroidal melanoma, but this looked more like a metastasis. We weren't sure. We did a biopsy. It turned out to be a melanoma as well. There was a little bit of bleeding during the biopsy, but unfortunately it bled afterwards in the week later with a submacular hemorrhage. So you need to understand that this is a procedure that can cause severe problems, in particular in tumors close to the fovea. Retinal attachment is surprisingly low rate of this, in less than 1%. Severe but rare complications are tumor seeding. We haven't seen one in the last 10 years, but we've seen one in the early days of our biopsies, and endophthalmitis, which unfortunately happens perhaps once every 2 years in these cases. Again, we try everything to prevent it, obviously. So what are the limitations? Basically, your setup is the limitation. You need good surgical skills, and we're very fortunate that I work in a team with Karl Grunwald and Rumana Hussain, who are excellent surgeons and very, very good in doing these biopsies. The lab skills are really, really required. There's only a few cells there, as you could see in the video, and you need to process them in the right way. And obviously the pathology skills, without somebody at the other end being able to really interpret these cells and identify them and make a call on them, that needs special skills that you won't have in every hospital. Regarding the lesion, what are the limitations? Close to the disc is difficult because of the big vessels in the way. We try to avoid it, and we can do biopsies in these. You see the little biopsy site, and on OCT it is possible, but these are getting tricky. Regarding the size, approximately 5 millimeters in diameter, 1 millimeter in thickness, but you can't run away from them all the time. This even was a pregnant lady, desperately wanted a biopsy before she had any treatment being pregnant. We did a biopsy, turned out to be a melanoma, and after plaque treatment, you can see the biopsy site. Unfortunately, everything went well. And finally, the limitations are the psychological side of things, the impact on the patient, the risk-benefit analysis, is this really worth it, and the patient's choice, really. We never force a patient into a biopsy, it's always patient's choice. Thank you very much for your attention.
Great. Thank you very much, Hanno. There is a question in the Q&A. What is the thickness threshold to perform transretinal biopsy? And Jens answered from that it is they would like to have a lesion higher than 1 millimeter. Have you had biopsies in smaller lesions than 1 millimeter?
Yes, we had, and we have no cutoff point really. To be honest, if it's less than 1 millimeter close to the fovea, then we usually, in inverted commas, try to really discuss with the patient, is it worth it, and try to talk them out of it, to be honest. But we don't have criteria where we say, no, we won't do it. The patient has to understand what this is for. The patient has to understand the risks. And if the patient, like this pregnant lady who wants to do a biopsy on a pregnant lady and a tumor above the macula, no one, okay? So I put it on Karl's list or on Romana's list, and then they might not know that she's pregnant, and they just do it. So these are things that, I'm not saying we have no exclusion criteria. There are cases where we don't like to do it. I personally find the ones at the disc the worst, sort of the small ones at the disc with the big blood vessels. And if you think you have enough space between the blood vessels to go in there, and as soon as you touch it with a cutter, you can see how the blood vessels go down to the cutter. And you think, oh my God. And I've seen during a different surgery, one of these blood vessels being nicked, and you don't want to ever see it again. So it's something that I really, really have a bit scared of, but there's no cutoff point. And I think Romana is analyzing our data on the very small ones, 1 millimeter or less. But we try everything. But as I said in the talk, less than 1 and less than 5 millimeters side to side, they usually go hand in hand. We hesitant, but we don't say no.
Romana just noticed that the smallest she has done is 0.4 millimeters. But this was tricky. This was tricky.
The way to do it is you have to lift the retina. That's a trick from Karl Grunwald. So you can't just go and cut because you're cutting retina. So you have to make a localized retinal attachment over the lesion, and then, like a vacuum cleaner, turn the cutter around and try to vacuum scrape it off the sclera, basically. But I would be lying if I say not a problem. These are things that you don't want to have 2 glasses of wine the night before. So these are tricky ones. Yeah.
My impression was, in some cases of small lesions, that when you go into the lesion, then it is so compact, this small lesion, that you tear the entire choroid, and I was really afraid that I will cause some suprachoroidal hemorrhage in this situation. But fortunately, I haven't had this complication yet. But
Yeah.
I must say that you stated that you have a missed yield of approximately 5% in pathology and 10% in genetics. In our setup, I must say it's pretty much the other way around. We need less material for genetics because it extracts the RNA, and we probably have more than 10% failure in histology.
Yeah, a couple of points to that. Very good point. Number one is we used to do genetics only with histology because we don't want to take the genetics from a cell you don't know. So we always did, yes, it's a melanoma, and then the analysis. However, even in small lesions, sometimes you're almost sure that it is a melanoma, and you want to know, is it monosomy or not? So if we as clinicians say this is a melanoma, and the pathologist says, look, there's not enough material for both, make your call. What do you want? Do you want histology or genetic analysis? There is sometimes we go for the genetic analysis in this, really. There's a good question is how much material do you need? Another reason why our rate is getting bigger is because we talk to the patients and they're so disappointed when they don't get a result. So to our threshold is really our eyes, that we take out the biopsy specimen, we look at it, and you need to see blocks of cells in there with your own eyes. If you don't see them, don't send it off. Guaranteed it's a negative result. So you can then think, I either go in again, even if it's bleeding, I want the result, or you say, I call it quits here. But our threshold really is that you, as the biopsy surgeon, can see clumps of cells in that, as I showed in the video. This is what we're aiming for. The only difficulty is if you have a lot of hemorrhage in there, then blood will mask everything, and you don't really know how many cells there are. But I think our biggest driver why we get better results is the disappointed patient.
And may I ask on the technique, do you aspirate manually with a syringe, with a 3-port, or how do you do this exactly?
Yeah, very good question. I didn't have time to show all of this, but what we do is we have our normal 23 gauge setup, 25 or 27 gauge, and in the cutter line, we put a 3-way tap. You cannot aspirate because all the good stuff will get stuck in the tubing and in the cutter. So the best cells are actually in the cutter. Okay, so the way you do it, you cut for about a minute or so, or until you see the first cells arriving or blood in your tubing system. And then you go to the 3-way tap and inject retrogradely the BSS to flush out everything out of the cutter. And we do that a couple of times. Okay, in this way, you get a lot higher yield. If you got it all in there and then try to, with a suction, to get it into the syringe, you get, I would say, 5 or 10% of the cells. All the good cells are in the cutter, so you need to retrogradely flush them out.
What kind of machine do you have to use that you use for this? I'm asking because the Alcon machine, it's not very long, the tubing, until you have the first connection line. It is about this size.
Yes, and this is why you need a good nurse to watch you. So the worst thing is if the good cell material goes past the 3-way tap, then it's in the tubing, it's on the way to the machine. And then you have to aspirate that out of the tubing. So the nurse needs to watch until it's just about where the 3-way tap is. And then you stop the biopsy. But if you see it in the tubing, I'm happy, because that means I've got a lot of material. The worst ones are exactly as you say, the ones that are like leather. And actually the worst ones are nevi to biopsy, because they're there for 15 years. They are like leather, and it's awfully difficult to get a biopsy out of them.
Thank you for your comments. I think you could go on with the next speaker.
Okay. Next speaker is our friend Miltos, who is now in Essen. Unfortunately, he left us. He didn't like England and went to Germany. He likes it better, but he's very successful there. And I hope you showed them how to do it, Nick Miltos. I'm really looking forward to your presentation on the surgery. Thank you.
Yeah, colleagues, I would like to thank the organizing committee for including me in this webinar. In the next few minutes, I will speak to you about the indication and techniques for surgical excision of uveal melanomas. When we speak about surgical excision, we speak actually about large tumors, and we base our therapy in this photograph. This from a publication published last year from Professor Bechrakis and other colleagues from the leading oncology centers in Germany. The publication is written in English, so you can also read this. But we refer to these tumors which are higher than 7 millimeters, and what we can do then, we either do a proton beam irradiation and an adjuvant resection, or a stereotactic irradiation plus adjuvant resection, or we treat them with the iodine brachytherapy. In case of a risk of toxic tumor syndrome, we proceed with the resections as well, and these are either the endoresection or the transscleral resection. And we will start with a transscleral resection, which means that we remove the tumor from the outside. The indications for the transscleral resection is the uveal melanoma with the largest basal diameter not exceeding 18 to 18 millimeters, which is about a quadrant of the globe, and the distance of the posterior edge of the tumor from the fovea or optic disc should be greater than 3 millimeters. We now speak about a complex surgery with in hypotensive and hypothermic general anesthesia. That's why the anesthetist has to give us the green light. How does it work? You can see here we prepare a flap of the sclera, and then we see the tumor from the outside. We cut this flap, separating the tumor from the retina, and then close it with many sutures. And now we'll show you a video how it looks like. Here you can see a patient where we did the surgery in December. If a muscle is over the tumor, we need to remove the muscle, find the vortex veins, cauterize them, mark the tumor with the marker here, and then cut the edges, the anterior edges of the around, then preparing the flap. You can see here a ciliary artery and a ciliary nerve. We will cauterize the artery in order to reduce the bleeding. Afterwards, we always perform an anterior vitrectomy to have the eye hypotonic. It's much easier to prepare the flap when the eye is hypotonic. In the posterior part, this is another vortex vein, and then we start cutting the tumor actually all the way around the inner flap of the tumor, and you can see we will go 360 and then start separating the choroid, the normal choroid, the tumor here from the retina. This is the retina, what you can see here, and of course we will go 360 and then separate the tumor, remove the tumor very carefully, and what you see here is the retina actually, and the hair palm of the patient, and then we close the flap with many sutures. Now, this is the patient 4 weeks after the surgery. You can see here a little bit of retinal detachment here with subretinal blood, but the posterior pole is actually very good. This is our scheme, how we follow up the patients after uveal melanoma treatment. We normally check the patients every 3 months, but when we are talking about resections, then we don't stick to the protocol. Most common complications are choroidal and vitreous hemorrhages following transscleral resection. This many times happens in theater, so you can see here on the left side the photograph from the theater from this patient. You can see the red reflex, which is gone afterwards at the end of the surgery. So these patients need to follow up on the ward. You can see here the ultrasound, where you can actually say what is the retina, what is blood. You can suppose that here is the retina and this is a blood clot, and this one, and over the retina as well. So this is the second surgery. Then we need to proceed with a second surgery with these patients during in-stay. And after doing the phaco, you go into the eye with a vitrectomy, and you can recognize where is the retina. Is this the retina over there, or is this a blood clot? But after many time, and you will find the retina, and you can see here the posterior pole of the tumor as well. Here is the fovea. You laser everything all the way around and put silicone oil into the eye. And this is how it looks like a couple of weeks on the right side, a couple of months following the surgery. Here you can see a detached retina and a pretty good result for such a surgery. Not all patients will need a second surgery, such as this one here, where you can see a very good result after 6 days, just 6 days following surgery. There's another patient we treated last week. We removed a tumor, and then there was hyphema and a retinal detachment. So we proceed a couple of weeks later with the second surgery, and you can see here, after doing the phaco, we proceed with removing the vitreous. Here is the infiltration of the vitreous of the retina, as well working subretinally to remove the subretinal blood, and then proceed actually with heavy liquid, laser all the way around, and silicone oil. And this was the tumor we removed from this eye, and that's how it looks like a couple of weeks afterwards. So sorry, this 2 days following the second surgery with an attached retina. And we will move then to the following up. We always follow up these patients to exclude a recurrence and further complications. You can see here a tumor which is based to the inferior nasal part of the eye. The tumor was excised, and then there was a pigmentation on the side of the tumor, but on the other side of the tumor as well. This was a recurrence, and the eye had to be removed. But not all the patients will get a recurrence or a second surgery. You can see here in all of the results are pretty good, also with a very good visual acuity sometimes. Or here you can see a patient who didn't need a second surgery. This is a blood clot under the retina 1 year, but still with a radiation-induced maculopathy. And then we will move to the endoresection, which is the removal of the tumor from the inside. The thickness is not that relevant, because we are going to remove the tumor through a pars plana vitrectomy, but the largest basal diameter of the tumor should not exceed 16 to 18 millimeters, and the distance of the tumor to the optic disc and the fovea are relative, as we can go up to the disc, and we can also remove tumors very close to the macula. How does it work? Pars plana vitrectomy, removing the vitreous, start removing the tumor, start separating the tumor from the retina, then proceed with heavy liquid, laser everything around, and put silicone oil inside. Another point I would like to address here is the Pave, which was already published from Morris and 2013. If you've got your infusion cannula under the choroid, then air could live through the vortex veins and come into the systemic circulation and the patient could die. What we actually have during the endo resection is that we lose heavy liquid over the vortex veins. After many discussions with many colleagues, with Professor Hyman as well from Liverpool, we decided to cauterize all the vortex veins, as you've seen in the video, the vortex veins that come away from the tumor, and since then we don't have any loss of heavy liquid. We also close follow up these patients during in-stay. You can see here early complications, silicone oil in the anterior chamber or hyphema, or retinal detachments or choroidal detachments. You can see here the choroidal detachment. We will wait for a couple of weeks. If it persists, then we will proceed with a second surgery and cut the choroid here, relaxing choroidectomy with pretty good results actually following the silicone oil removal. As I already mentioned, silicone oil in the anterior chamber. This is a phakic patient. We do a phaco surgery also by all our patients before the endo resection. Hyphema will come up with 11% of our patients, retinal detachment as well, but still in 70% of our patients we will be able to remove the silicone oil. We also here need to exclude a recurrence. As you can see here on the top, after the endo resection, the tumor grows towards the optic disc. This was successfully treated with 2 times TTT. Smaller recurrences can be treated with TTT. Large ones would need a brachytherapy, or in this case, as you can see, the tumor grows all around the optic disc, and enucleation will be needed. Radiation-induced maculopathy or radiation-induced optic neuropathy are late complications and may come up in 40% of our patients. But still, the results are pretty good. You can see here a very large tumor, 10.4 millimeters in thickness, 15 months following surgery, attached retina, and here a young patient 8 years afterwards with a very good visual acuity. Or here another 10 millimeter tumor on the left side following surgery and removal of silicone oil, or on the right side following surgery and removing the silicone oil, but still with radiation-induced maculopathy. To summarize, surgical resections, either the transscleral resection or the endo resection, offer very good local tumor control rates. As well as eyeball salvage rates are very high. We never should forget that these tumors are very large, and the only treatment at the other treatment would be to remove the removal of the eye. So we save the eyes in 80 and 95%. These resections should be done in specialized centers. The indication for a local resection should be made individually. We always combine these surgeries, either adjuvant or neoadjuvant, with radiation therapy. And as I mentioned before, local resections offer high eyeball salvage and high tumor control rates. Thank you very much for your attention.
Thank you very much, Miltos. That was an excellent presentation. Just a quick comment to the Pave syndrome. So you can get air embolism with this surgery if you don't look after the vortex veins. And actually, there was a case published here in the UK last year with heavy liquid only. So you cannot prevent that by not using air. You can get it with heavy liquid as well. And this is why, exactly as you said, we would recommend in the area and wide area of the endoresection specimen, we would recommend to look at the vortex veins and cut them. This is no negative advantage of it on the surgery. So Miltos, one question, sometimes you have tumors in between endoresection, exoresection. What would be your choice if you could do both?
Depends on the ciliary body. So if we've got ciliary body involvement, then we'll proceed with an exoresection, with a transscleral resection. In our hands, when we do an endoresection with ciliary body contact of the tumor, you can just remove the ciliary body, because then you need to remove the the zonules, and then the lens will be unstable, and we already experienced this, that the lens actually goes into the vitreous. So for us, it is ciliary body involvement, then transscleral resection without ciliary body involvement, then endoresection.
And for the endoresection, do you do special anesthesia as well, or do you leave the blood pressure just as normal?
No. In essence, we just do a normal anesthesia.
And I think quite rightly, I fully agree with you that you need some type of radiotherapy before or after. Can you quickly comment on that? What's your favorite regarding this?
So we perform it before. Either with we don't do any proton beam irradiation before the surgery. We prefer the stereotactic or the gamma knife, just single shot 22 gray, and then we a couple of days or 1 week later we perform the resection.
And have you seen any kind of seeding along the ports with endoresection? No. That no, or into the anterior chamber or something like that, local seeding? Very good, very interesting.
Of course, you know, it is the one who does the endoresection has already experienced it. So when you cut into the tumors, you've got thousands of cells going around. That's why we changed our opinion, and now we do all the radiation before the endoresection.
Okay, very good.
This discussion with Lyndon da Cruz a few weeks ago, who actually reported in a meeting in Athens on some fatalities, I think 2 cases from London, and that after endoresection with, not with perfluorodecaline, but with octalin, I think. So the question is the ability of the heavy liquid to become vaporized within the blood system. And I mean, I haven't had many patients that have lost perfluorodecaline somewhere, probably in the circulation, but I truly never had this problem. And but I've never used hexalin or octalin. So I am curious whether this is the main issue, that if you have decalin, this vaporization within the heating within the circulation is not that significant as compared to the octalin. Do you have any comments on that?
Yeah, as far as I understand, there was 1 case in London, but there were 2 cases in Thailand, basically with the same and about to be published. I know of more cases that was conference talk, so I can't really talk about it, but other colleagues have said that the same, that they had embolism without any air and using just sort of heavy liquid. Would be interesting to see if it's all the same brand of, as far as I understand, and the London group has put in a massive amount of really work into this to look really at everything. My argument always before was, you know, I was really complacent about it and said, if you lose heavy liquid has been used as a plasma expander, infused into your veins, basically. But they said, no, not all the heavy liquid is the same. Some of them you can, and some are just impure and do exactly that. And that's the problem about it. So I think that's very important, and we work all this up. The second thought I have on this, it's probably depending also on the pressure and the time you have the heavy liquid in there. So as you know, one of the big problems of the surgery can be, it can bleed a lot, and you have to do a hemorrhage control here, there, everywhere. And we would advise to do that all under fluid and not under heavy liquid, because you sometimes have pressures of 80 or 100, and then you push out the heavy liquid. So we only use it after all the blood has stopped, and then at the very end, before we put silicone oil in, we use heavy liquid for about 5 minutes or so, not longer than that.
But I think a very interesting issue is that what Miltos mentioned, that we have never seen egress of heavy liquid after cauterization and cutting the vortex veins. Yeah. We started with this about half a year ago, and I think it would be interesting to try to analyze these cases, although it needs a lot of effort to find out how many heavy liquid vials we used in the past. Probably we will be able to find it out, and maybe we should join forces on that issue.
Yeah, to me it's the logical step, because if you cauterize them and you don't need them at all really, then it cannot go in the circulation. Okay, do you want to introduce the next speaker, Nikos?
Yes, it will be my pleasure to introduce Jan Kilgart from Denmark, in Copenhagen. And Jan will talk on, can survival of uveal melanomas be improved? Very important issue.
Dear colleagues, dear organizers, thank you for inviting me to this SOE webinar on uveal melanoma. My name is Jens Volker Kilgart. I'm a professor at the Copenhagen University and Copenhagen University Hospital, Rigshospitalet. Today's subject is, can survival of uveal melanoma be improved? Several large cohort studies have shown that the death from disease-specific disease in uveal melanoma is about 50% after 15 to 20 years after diagnosis, indicating that 1 out of 2 patients with uveal melanoma will eventually develop disseminated disease, primarily involving the liver. In contrast to cutaneous melanoma, there are no good treatment options for disseminated uveal melanoma, but there are encouraging studies published in New England Journal of Medicine regarding tabentafusp. The poor outcome for uveal melanoma is probably due to the low mutational burden shown here on the right panel, where we only have 2 mutations, 1 driver and 1 initiator, in contrast to the left panel for cutaneous melanoma, where each dot represents a mutation in the tumor. Bill Harper's group from Miami investigated 139 primary uveal melanomas and found that the mutational burden was very low. They also identified that the mutational changes happened exclusively in the tumors, and they were able to identify 2 to 3 groups, 1 low, intermediate, and high risk group for developing metastatic disease. This led the group to propose the hypothesis that these early exclusive mutational changes defined the fate of the patient regarding no matter what treatment was given to the patient. The problem with the uveal melanoma metastasis is that they can occur very early, but they can also occur very late, up to 42 years after the primary diagnosis. And this concurs very poorly with a hypothesis of a punctual evolution of metastatic disease. We therefore wanted to investigate a bit more about the metastatic evolution, and we set out to analyze pairs of primary melanomas and their liver metastases. But before we go into this, I'd like to talk a little about mutant allele frequency. Imagine a tumor arising from one mutation, undergoing different mutations, are analyzed by a biopsy. We can now take the different population of genetic subpopulations and identify the number of new mutations. Whereas the first mutation will be present in all the cells, the next mutation will only be in a fraction of the cells, and the last mutation will be in the smallest fraction of cells. It is now possible from the different fractions of mutations to make a graph of the evolution of the tumor. Shown here where we have mutation 1 giving rise to the primary tumor and a new mutation 2 giving rise to metastasis. As all cells have 2 alleles, we will find the mutation in 50% of the alleles in the primary, but also in 50% of the metastatic cells. Whereas mutation 2 will only be found in a fraction of the primary melanoma, but you will see it in 50% of all the alleles in the metastasis. Now imagine you have a third mutation rising in the metastasis. This mutation will only be seen in the metastasis and not in the primary melanoma. Now let's go back to the patients we analyzed, where we could show a mutational map. And from this map, it was possible to draw a phylogenetic tree, where we see mutations unique for the primary and unique for the liver metastasis, indicating that this took place after the metastatic seeding. But we also see genetic changes that are common for both the liver metastasis and primary, indicating that this took place before the metastatic seeding. If we now look at the total cohort, we see that the metastatic spread often took place before the diagnosis of the primary tumor. We also see that the changes of chromosomal abnormalities increases with the development of metastasis, leading to the hypothesis that the development of uveal melanoma metastasis is a gradual situation where we have the melanocyte evolving into the precursor lesion, evolving into the primary tumor. But already very early, we do see that some of the cells are giving rise to micrometastasis seeding. But as the tumor evolves, you have more and more metastasis seeding, and eventually you have macrometastasis developing. This hypothesis was confirmed by Bill Harper's group, which also showed that evolution of metastasis happens in a gradual way. We know from our cohort studies that patients with normal chromosomes have a better survival than patients with just loss of chromosome 3 or gain of chromosome 8q. And patients with a combined monosomy 3 and 8q gain have a very poor prognosis. We also know that smaller tumors have a smaller fraction of abnormal chromosomes compared to larger tumors, reflecting also that smaller stages of ATCC tumors has a lower fraction of abnormal chromosomes compared to larger stages. We now went back and investigated the survival and incidence in the Danish cohort over a 70-year period. And due to large changes in both society, but also in the age distribution of Danish patients, we used the age period cohort model rather than the age-adjusted incidence rate, because the health status in the society also changed dramatically during these 70 years observation period. And interestingly, we saw that the survival of patients with small tumors actually improved during the period, whereas patients with large tumors had basically the same survival over the whole period. We also found that the incidence of uveal melanoma is rising in Denmark, and we now have about 12 per million persons. And this rise is primarily seen in small melanoma patients. Just to ensure critics that we are not treating a nevi, we here have a plot of all the tumor heights for patients treated, and we see that there is a trend towards a lower height, but this was not statistically significant. What has happened is there's been more centralized treatment of tumors in Denmark, so it's now only treated in 2 major centers. The problem with epidemiological studies is that you are following a cohort, and at the end of the study, the patient is either alive or dead. And from these data, you can draw a Kaplan-Meier curve. The problem is sometimes you include patients that are lost to follow-up, either because they immigrate or because they die from a different disease or cancer. And in these cases, you need to do a analysis taking in care of competing risk, because you cannot die from disease-specific disease if you have died from a different reason. But the biggest problem is the inclusion of patients. So if you start to look for the patients or even initiate a screening program, you find patients earlier, and thereby you are giving them a longer observation period and a false improved survival rate, also called a lead time bias. If you want to take this into account, you need to look for the relative survival, and we also did this in the Danish cohort. Shown here on 4 panels, where the blue line represents the background survival and the colored graph shows the individual tumor sizes and survival. And what you see is in the two later periods from 1981 to 2017, the survival of small melanomas is actually identical to the background population, and you also have improvement of the T2 tumors compared to the two earlier time periods, whereas the larger tumors has the same survival rate in all 4 periods. In addition to death from disease-specific disease, we also find that the uveal melanoma patients has an increased risk of developing a new primary cancer. And in panel A, you see the black curve representing the risk of cancer in the background population, and you see the red curve for the uveal melanoma patients, and you see that the two curves cross over, indicating that in the first part, the uveal melanoma patient actually has a higher risk of developing new cancer compared to the background population. For the sub-analysis done in panel C, you see that patients with small uveal melanoma actually survives and are able to have a lifelong increased risk of a new cancer, whereas the patients with higher tumors actually die from the disease and therefore cannot develop a new cancer. In summary, the evolution of uveal melanoma is gradual, and the metastatic proclivity of a given tumor is not set in stone, indicating that earlier detection and treatment of uveal melanoma is beneficial for the patient. For larger tumors, dissemination of disease has probably already been taken care of at the time of diagnosis. We stress that uveal melanoma patients has a lifelong elevated risk of developing other primary cancer, and we will suggest that metastatic disease is validated by histopathology in order to not overlook a cancer which could have been treated with chemotherapy. Thank you for your attention.
Thank you, Jens. Fantastic presentation. Just to put you on the spot again, are you in the early treatment safe life camp or in the other one with the horses bolted?
No, I definitely agree with Romana in her talk that we need to treat early. We need to find the monosomy 3 tumors before they get the 8q gain. And it seems like in metastatic disease, it's the 8q gain which is really the major player here.
And when we talk to the patients, they are asymptomatic. It's close to the fovea. We know we're going to harm their vision, and they tell me, "What's the percentage? What's the gain? How many lives do you save if you treat 10 patients like me?" Do you have any idea based on your data?
That's a really, really good question. So the short answer is no, I don't.
Yeah.
But the problem is that we do see now we have been taking biopsies for more than 12 years, and we have these high-risk patients we follow each year, and we have some with small monosomy 3 tumors which apparently do not die. The problem is the very late metastasis. So if you ask if you're going to save life, we don't know, but it's my clearly belief, and this is something I can do in church, I know that, but it is my belief that that we will definitely prolong life if we try to get them before they actively have these 8q gains. So I think the 8q gain is the major player.
And so the question is, we do all these biopsies, and let's say we have a completely normal chromosome 3 and 8, and it's close to the fovea. Would you then perhaps base your recommendation for treatment on that result, or not really? Would you say it can still go in the other way?
Yeah, so I have the luxury of getting a completely normal chromosome for very posterior tumors. We don't see that. I don't know why we always have monosomy 3 in our posterior located tumors, or maybe we are too late to biopsy. Maybe we need to do more biopsies. It is also a question. But if you have a completely normal chromosome and you have all the other risk factors, no, I would still treat them, because it will probably just a matter of time before they have their changes.
And there was a comment about tebentafusp in the chat, licensed obviously today, as we learned in the chat. Do you have any comments on that? Is there any link to your biopsy results? Can you filter out patients that may benefit from it?
Yes, we will start looking for HLA A2/0 subtypes
So we don't know right now how many of our patients actually have that subtype. But benzafusp is only prolonging life. It's not really saving lives, but that's still a huge, gigantic step towards a better treatment of these patients, which basically always have been considered like being lost life. When you have a melanoma, if you die from it, you die from it. And that was the end of the story. But it seems now we can actually change that. And I think that's great news.
And for the audience that hasn't heard from it, can you in 2 sentences say what it is and how it works and what it does?
Yeah, so it's a protein that binds to the GP100 on the T cells, and it also binds on a receptor on the melanoma cells. And what it basically does, it makes the immune system attack the cells, and then it doesn't hide from the immune system, which is a major problem with our tumor cells, is that the immune system seems to be doesn't care. They don't see the cells. So the GP100 molecule can be used to attack these cells. So it's an elegant way to do chemotherapy in these patients.
And do you have an idea how many patients benefit at the moment? I mean, it's a starting point, isn't it? Yeah.
For the article published in Unit, it seems like it's about a third to a half of the patients which could benefit from this treatment, but I don't know the data for this. It needs to have this special HLA subtype.
Mm-hmm. Thank you, Nikos. Do you have any questions?
I would like to ask you about surveillance. Do you make a difference on surveillance, watching the patients to develop metastasis, stratifying them in high or low risk patients?
Yes. In Denmark, we only have a certain amount for healthcare. Everything is free, so we need to be very careful to choose the patients that needs the follow-up. And we have now actually put all the high-risk patients into ultrasound surveillance, and all the low-risk have no surveillance. And we have lost one patient in the low-risk group due to this strategy. That's unfortunately, but it seems like all the other biopsies gave us the correct answer for dividing them into a high and low risk group. So we've continued to do that because, yeah, it's very nice to tell the patients you don't have a high risk, you don't are at risk from dying from this. We got the disease in good time. And for the high risk patients, they actually change their life. So when they get the knowledge of having a high risk profile, they start living their life in a different way, and basically they actually do appreciate the knowledge we give them. And we also say to them, this is not a death sentence, because only half of the high-risk patient will actually eventually die from metastasis. So it's only the last half, or 40%, which will die from the metastasis. Yep.
Thank you very much. Hanno?
Nikos, you want to introduce the last speaker?
I think this is your privilege.
Okay, Eva Beaver then from Essen, from your center, talking about retinoblastoma, please. Thank you.
Thank you very much for the opportunity to talk to you on salvage therapies in the treatment of retinoblastoma. Sometimes the different non-treatment options are not sufficient in the management of retinoblastoma, and therefore I would like to talk to you in the next few minutes about proton beam therapy as a new treatment approach in pre-treated retinoblastoma eyes. And the last minutes of my talk, I would like to talk about the modified enlarged enucleation via lateral orbitotomy for retinoblastoma with postlaminar optic nerve infiltration. So what are the advantages of Pbt if there is non-avoidable radiotherapy? The effectiveness is comparable with EBRT. We have a lack of an exit dose and a small penumbra, resulting in less radiation damage to collateral tissue. And therefore, we hope for a reduction of ocular side effects and the reduced probability of radiation-related induction of secondary primary malignancies. What is our treatment technique? We use 2 dental markers. They are sutured to the nasal sclera to make sure that the eye is in correct position while PBRT is performed. then the gross tumor volume and the clinical target volume are defined in cooperation between treating ophthalmologists and radiation oncologists, and then the radiation field is being constructed. For treatment, we used the Proteus Plus therapy machine, and we did a fractionated irradiation with 2 grays per day for 25 days of irradiation, leading to a total dose of 50 gray. Let's have a look at our patients. Recruitment period was from February 16 to August 2018. We included 15 eyes of 13 bilaterally affected children. Mean age was 35 months, follow-up 22 months. Indication in all patients was the rescue therapy in advanced retinoblastoma disease as last option for eye-preserving therapy. Here you see the initial findings, demographic data, and treatment prior to proton beam therapy. I don't want to go too much into detail. I just want to point out a few things. So you see that we treated one group E eye. We treated 2 children bilaterally. Youngest patient was 14 months old, oldest patient 97, and you can see that all of them had quite a range of different treatments before we started proton beam therapy. Here I would like to share with you a clinical example. On the top you see the irradiation plan of one of our patients. The gross tumor volume is shown in red, the clinical target volume is shown in yellow, and here you can note the sparing of the lens and the small bony window, and on the bottom you see the clinical appearance of our patient. So we had 2 recurrent tumors close to the optic disc, and after Pbt we had a complete regression now over a follow-up of more than 16 months. Let's have a look at our results. Globe preservation rate was 60%. That means that 6 out of 15 eyes showed a need for secondary enucleation. Indications for secondary enucleation were optic nerve and choroidal recurrences, loss of tumor control with consecutive blindness in 2 eyes and a phthalmic globe in 1 eye. We found vital tumor cells on histopathological examination in 4 eyes, which is not surprisingly, as we saw that in 3 eyes on clinical examination. Here's one of the patients we enucleated due to a recurrence. Here on the left, you see the tumor recurrence of the centrally located type 3 regression 8 months after Pbt. And on the macro photo, you see the enucleated specimen with a massive choroidal infiltration. What were our adverse events? We had a radiation-induced cataract in 4 cases. Those were patients where the lens could not be spared due to tumor localization. Time interval between Pbt and cataract induction was 22.5 months on average. We had 1 patient with a perforated corneal ulcer and 3 patients with radiation retinopathy. Unfortunately, 2 children developed a metastatic disease, but then again, none of our patients so far developed secondary radiation-induced malignancies. So let's move on to the modified enucleation. Indications for that surgical approach are post-laminar optic nerve involvement. We all know that a tumor at the cut end of the optic nerve worsens the prognosis, as it is a known risk factor for metastatic disease, and therefore upfront enucleation without any neoadjuvant chemotherapy allows the exact pathological analysis of extraocular intention, and that is the key to management with appropriate surveillance and adjuvant therapy. So what was our treatment technique? We did the initial surgical steps of enucleation with disinsertion of all muscles. Then a lateral orbitotomy via bicoronary incision was performed by our colleagues from oral and maxillofacial surgery. A long optic nerve stump was cut and completely removed along with the globe, and in all cases we used an implant. I would like to show you some pictures of this treatment technique. On the left, you see the initial findings of the group EI, and on the right, you see the marks for the bicoronary incision. So it's a large surgery. The surgical excess was carefully prepared, and then the lateral orbital bone was removed. You see that here. In the next step, the optic nerve was located and transected and completely removed along with the globe. The bone was then refixed, and the excess roots were closed. And on the right, you see the post-operative picture of one of our patients only 3 days after surgery. So let's have a look at our patients. Recruitment period was from November 17 to December last year. We included 8 patients with presumed extended optic nerve involvement on MRI. Clinical features, mean age of our patients was 27 months. 8 or all patients were suffering from unilateral disease with group EIs on initial presentation. 3 patients had a pre-enucleation chemotherapy for various reasons, whereas we did an upfront enucleation in 5 patients. Here, one clinical example. On the left, you see the RETCAM images of an advanced retinoblastoma, and on the right, the corresponding MRI scan. And here you see the intraocular tumor masses and the presumed optic nerve involvement. Let's have a look at the results. In the group of the children that received pre-enucleation chemotherapy, we found no signs of optic nerve involvement on histopathological workup. Those were 3 out of 8 children. On the 5 children where we did upfront enucleation, we found an optic nerve involvement in 3 cases, whereas the evaluation on the MRI scan was false positive in 2 patients. Here you see a histopathological slide of a massive optic nerve involvement. Average length of the detached optic nerve was 11.7 centimeters, ranging from 7 to 13 millimeters. The cut end of the optic nerve was free in all cases. We had an indication for adjuvant chemotherapy in 5 patients. Those were all patients with an N2 optic nerve involvement. None of the patients received an adjuvant orbital radiation, and unfortunately 2 of our children died due to a leptomeningeal dissemination. So to come to an end, I would like to summarize that Pbt is an effective rescue therapy in advanced retinoblastoma eyes with no other treatment options. Our preliminary data suggests that the risk of radiation-induced secondary malignancies is significantly lower when compared to EBRT, and the modified enucleation allows pathological analysis of extraocular intention, which is the key to adequate surveillance and adjuvant therapy. Thank you very much for your attention. I'm happy to take questions.
Yeah, thank you very much for this excellent presentation. As you already alluded, I think probably secondary malignancies would be on top of the list of the concerns. As far as I remember, this was also age-dependent, wasn't it, in the original studies? Do you feel you have an age where it's safe to do it in any case and it's not influenced by the technique? Or what are your thoughts on this?
So we always try to have children at least 1 year of age before we do radiation of any kind. It really doesn't depend on Pbt or EBRT, but sometimes you have to do that before they reach the age of 1 year. And for now, I can't answer the question whether or not we have an age where we have a lower risk of secondary malignancies. We only know that before the fulfillment of first year of life, it's difficult.
And the second part of the talk, the importance about knowing whether there's optic nerve infiltration before and how long it is. that basically would speak that every patient, if possible, should have an MRI beforehand. So centers shouldn't just go ahead and say, oh, this is a unilateral retinoblastoma, I just enucleated, even because with a regular technique, perhaps you can comment on that. What's your normal length of an optic nerve head with regular technique? And you probably would advise against that, doing it outside of centers then. Is that correct?
That's true. So in our clinic, all patients get an MRI scan before we do enucleation, just to make sure that the optic nerve is free or presumed free. And when we ophthalmologists do the enucleation, we get an optic nerve stamp 5 to 8, 9 millimeters if we are lucky. But then again, it gets complicated when you have a ophthalmic eye. Then it's a little bit more difficult, and then again, you are under pressure when you know that you need to get a long optic nerve stump. So when we have a longer optic nerve involvement on the MRI scan, we ask our colleagues to come and help out.
One question from the forum is it really, really, really necessary to do an orbitotomy, or isn't there any other way of long scissors or something that you could use?
I don't think so. Probably Mr. Bechrakis wants to answer again, but I would say no.
I don't think that you need to have a reliable length of your stump. If you have the impression on the MRI scan that there is a infiltration of, let's say, 5 to 6 millimeters of the optic nerve, I don't think there is any way that we ophthalmologists can be pretty sure that we will get this length of a stump. So I think it would be much too risky to just go on and make the surgery by ourselves. And as Eva just alluded, I mean, these eyes are really difficult to enucleate. They are large, usually they are larger than normal eyes for these small kids or babies. And the orbit is very narrow, and it's really difficult to get a long, to be sure that you will get a long stump. If you have the unfortunate situation that you will cut through the infiltration, then you will get in a lot of trouble with recurrence in the orbit. And I think I don't think it's wise to risk this. So that's why we take this pretty major surgery. But and as you saw from the results, still there were 2 little children that lost their lives because of leptomeningeal dissemination. So even this is not absolutely sure that you will avoid metastatic disease. And there has been a paper showing that there might be this infiltration of the optic disc of the optic nerve very proximal to the eye, that the tumor will probably go through the meninges, the pia mater, through the arachnoid, and then well, you can only find this out by liquor puncture, and unfortunately we were not able to determine this beforehand.
So I presume in the cases with the disease, the infiltration did not go up to the cutting edge. The cutting edge was free. Oh,
yeah.
Yeah, so then you couldn't prevent it no matter how long you cut the optic nerve. One more question from the forum is a steel loop to cut the optic nerve head. Do you have any experience, or do you use just scissors? What's your comment?
I never used this loop. We only use scissors.
Yeah.
And in England, unfortunately for children, we have to use single-use instruments, which sometimes are not the best. Is that the same in Germany or in other countries, as far as you know, or you have proper German scissors that you can sterilize? Or
yes, we have proper scissors.
Okay.
So we use reusable scissors.
Okay. And the last question is, how high is the sensitivity of lumbar puncture to detect leptomeningeal dissemination? Do you know, is there any research published on it?
Very good question. We want to work that up and have a look on how many children really do have vital tumor cells on lumbar puncture, but our feeling is that we don't see a lot of vital tumor cells, but we still do it when before we start enucleation. It's part of the staging system when we treat group E eyes, but as far as I remember, we don't see any at almost any vital tumor cells.
Okay, and very last quick short question before Nikos wraps up. Any role of local chemotherapy in the orbital stump with methotrexate, soaking it or so, in case you feel there's a local dissemination? Have you known of it, done it, experience with it?
We don't do it. I have no experience with that. Sorry, I can't concrete comment on that.
Me neither. Me neither.
Okay, thank you very much. That was a great talk and a great discussion. Nikos, you want to wrap up?
Thank you very much to all the presenters. Thank you very much for all your effort that you put into this webinar. And thank you to SOE for allowing us to do this. I think ophthalmic oncology and pathology is a very special subfield in ophthalmology, and I'm really glad that there are a lot of people that were interested in this seminar and webinar. Hanno, many thanks to you. Many greetings to Liverpool, and please note that the webinar was recorded, so you can shortly you will be able to see this on the SOE website. And if you are kind enough, after this webinar, there will be a short survey at the end of the webinar. You could, if you have some time, you could complete this. Once again, thank you very much for everybody, and thank you, Hanno, and thank you, SOE.
Thank you all. It was a pleasure.